Okay, thank you very much. On this panel, we're joined by three remarkable American public servants. Representative Karen Bass from California is the head of the Congressional Black Caucus and has a strong background in healthcare herself. Representative Joaquin Castro from San Antonio is the chair of the Congressional Hispanic Caucus and has been very involved in these issues. And Dr. Eric Goolsbee from the University of California in San Francisco is one of the world's most renowned public health doctors. He is the United Nations Special Envoy on Tuberculosis. He was President Obama's head of the PEPFAR program in President Obama's first term. And as I was just telling the other participants, in 2002, he was my partner when what is now the Clinton Health Access Initiative began our work, ironically, in China, when we were trying to help rural people in China stem what was rapidly becoming an epidemic unaddressed, as well as deal with the traditional urban problems of AIDS all those years ago. So we've been friends a long time. And these three people, I think, are in a real strong position to answer questions about the racial and economic disparities of this pandemic in the American population and things that we ought to be looking for as the problem spread to other countries across the globe. I'd like to begin with Dr. Goolsbee and ask the obvious question: why do we have racial disparities in both the infection rate and the death rate of the coronavirus in the United States?
Well, thank you, Mr. President. It's a real pleasure and honor to have an opportunity to speak to this issue. I think you're correct in convening this discussion. I think that what we unfortunately continue to see is a uncovering of the disparities in both availability of medical care and services and our ability to retain patients in care over the duration of time to accurately diagnose and initiate treatments that correct chronic progressive diseases in the African American community. And I think the COVID outbreak, as has happened so many times in the past with other outbreaks such as HIV, shows a disproportionate impact on those individuals who are not part of the medical delivery system and carry with them an inability to access medical information and services quickly, easily, in a manner that allows for work and activities of daily living to continue. You name the disease: hypertension, diabetes, coronary artery disease, respiratory infections, asthma, etc., all play out more negatively in the African American population. And this is a disparity that has been present for as long as I've practiced medicine and long before. I think it stems from a complex interplay of lack of socioeconomic equity that is institutionalized and manifests itself in everything from our ability to identify, enter, and retain individuals in care. And that inability to do that over time impacts differently on populations. And unfortunately, the COVID has shown us once again that African American communities are the target.
Karen?
Well, I certainly agree with everything that the doctor has said, but I would also include in there the unconscious bias of health professionals, because you can look at some disorders and you can see the disparity that exists across socioeconomic status in the African American population. And one that we're dealing with right now is a real increase in maternal mortality, which is something that is difficult to reconcile in 2020 in the United States, that maternal mortality would be a problem and that it would be disproportionate, and it is disproportionate across socioeconomic status.
Well, we just had a painful example of that in New York in the last week. And I'm not saying there was any racial motivation behind it, but a 33-year-old African-American man who was very overweight, but was also a responsible worker and a father, was in the hospital, not tested because we didn't have enough testing equipment. And they thought he just had a bad cold. And 3 days later, he dropped dead, leaving a widow and young children. So we're seeing that here. Joaquin, would you like to say anything before we go?
Yeah, thank you, Mr. President. Thank you for convening this discussion, an absolutely important one in the middle of this pandemic in our nation, the wealthiest nation on earth. But what this has exposed is some very long-standing inequities and challenges in our American society. And we see both the African-American population very hard hit and Latinos in different parts of the country also devastated. In New York, for example, Latinos account for 34% of the deaths because of COVID-19. In my hometown of San Antonio, the African-American population is 7 or 8%, but African-Americans account for 36% of the deaths. And so the numbers, we just seen different regions that have reported numbers. We have asked the CDC to produce comprehensive data so that we can see exactly what's going on. But obviously, it speaks to many of the failings in our healthcare system and other parts of our society that we absolutely need to address.
I agree with that. I want to ask you one thing, though. I noticed because I checked the population composition against the death rates in several American cities. And interestingly enough, even though there's a disparity in New York, and the gap between the population and the death rate is smaller in New York and California than it is in many other states. You know, in Louisiana, the population is 30% African American and the deaths are 70%. Same in a lot of the Middle Western cities. So what do you think the difference is in the disparity? Why is there so much difference in some areas than others? Eric?
Well, yeah, let me take a shot at that, Mr. President. I think it's, again, a multifactorial reason that African Americans and Hispanic communities in San Francisco and in Oakland, the East Bay, we're seeing a disproportionate number of Hispanics falling to both cases and deaths. So we see that a similar picture that you're seeing in Texas. I think communities that have jobs that are people-facing, interact with the public, lower paid jobs that start often as clerical, where you're interfacing with public in transportation settings as well, disproportionately occupied by African American Hispanic people. And that fact puts our communities in front of a threat that those that are not forced to do that are not put in front of. And I think the inability to, again, access and be retained in care plays out for all chronic progressive diseases and in acute outbreaks because of a similar need to identify, enter, and retain people quickly.
Anybody else want to comment on that?
Yeah, I also think that you have clusters of both African Americans and Latinos in states that have not set up the best infrastructure of opportunity for access to healthcare, for example. Texas, my home state, has the highest percentage of people that have no healthcare coverage at all. And the state is about 13% African American and about 40% Latino. So you have a lot of folks who are in places. Florida is another example that hasn't expanded Medicaid. Texas hasn't expanded Medicaid. Other southern states as well. You mentioned the difference between a New York and the South. I think that that's got to account for at least part of that equation.
And if you look at California, where the rates are still disproportionate, I mean, in Los Angeles, African Americans are 9% of the city and the county, but 19% of the death rate. But still, California, the resources are much better. The commitment here to provide resources to the entire population, including the undocumented population, I think has been helpful. But the disparity is still there.
I do too. Isn't the insured rate in California is well over 95%, isn't it? It's up to 97.
I don't know if it's quite that high, but it is high. It is absolutely very high because of the commitment. I mean, we're very fortunate. I tell that to my Californians all the time.
Well, when you get this in hand, I think that you can use that to really put the heat on these other states to expand Medicaid,
Right.
because there's no question that the absence of an underlying health network has contributed to the death rate among
But
all low-income working people, disproportionately concentrated in African Americans and Hispanics.
But, Mr. President, some of those same southern states are the ones that reject the public health guidelines, in terms of staying at home
I
and
know
all.
that, but I
It's
think,
just incredible.
I feel badly because Louisiana finally got a governor that would take
Right.
the Medicaid expansion, but he hadn't had time to have it in place long enough. And, a lot of what happened in New Orleans was because of Mardi Gras, I think, but still,
Right.
we've got to recognize that the health system itself has got to be built up. I wanted to ask you one other thing, all three of you, about something that doesn't directly affect you. I noticed, and there may be a lot more going on, but I know that in Northern California, there's a preliminary effort to do contact tracing.
Yes, Mr. President.
Paul Farmer,
Go ahead.
let me finish the question. Paul Farmer, the head of Partners in Health, who's a good friend of Eric's and mine and serves on the board of our health initiative, is heading up from Massachusetts an attempt to do contact tracing for the whole state. They don't have the people to do it now because we haven't built out the public health network at the community level we need. If they had all the people they need tomorrow, they don't necessarily have all the protective gear they need for these people to go and do the personal interface. But it's a good beginning. And if we want to put America's economy back on, we got to be able to test millions more people. We got to be able to take millions of people's temperature every day. And we've got to have workers that can be protected while they're doing this work. So I just wanted to say that because I think you're going to face all these requests for more money. But if we don't have a public health network that will stand up while people are beginning to go back to work, we're going to have all these problems flare up again.
Right.
So,
Well, I would really strongly agree with everything you said, Mr. President. I think that that is the bottom line, and it, I think, behooves all of us to understand those relationships and to ask of our political leadership that they focus on responding to this long-term unmet need. I just wanted to mention one of the other confounders as to why there's a disproportionate impact in both our Hispanic and African American populations with the COVID-19 is because of the propensity to have a more rapid course from exposure to infection and to move from infection to serious illness more rapidly, as you mentioned, who have comorbidities. People with congestive heart failure, with coronary artery disease, with asthma, and with diabetes have a disproportionate sensitivity to this coronavirus's ability to attach and intercalate its RNA into the cytoplasm of your cells. It attaches more efficiently. As a result, for the same exposure, more people exposed in the same way with those underlying diseases are more likely to incur an infection. And I believe that that is a major motor to favor Black and Hispanic communities, and we are indeed seeing this everywhere.
so what can we do through the Congress or elsewhere
Yeah.
to minimize it going forward?
So let me just mention that on behalf of the Black Caucus, there are very specific things that we are proposing. And we're proposing right now concentrated focused testing where you have large concentrations of African Americans and are a disproportionate death rate. What I'm concerned about now is that there's a lot of attention on the comorbidity and also on the individual behavior of African Americans, which to me just amounts to blaming the victim. But I think we need to do focused testing. We need to do the contact tracing. We need to make sure the testing, the results are back rapidly. I've talked to doctors where it takes 7 to 10 days. We also need the antibody tests. And then we need to have resources that go directly to community-based organizations so that people can be involved in the education work that needs to take place. I'm concerned that with the focus on the underlying health issues, that it then becomes an excuse to basically say, well, there's nothing we can do about it because you guys have all these health issues, and the situation is ignored.
Joaquin?
Yeah, we also support an aggressive outreach model. You talked about contact tracing. In many places in Texas, they stopped doing that and moved to a mitigation model after the different localities felt like there were a number of cases that involved community spread. A lot of them stopped the tracing. And so we've got to do that aggressively. We've got to test aggressively. In the Latino community, for example, you have, of course, overwhelming number of Latinos in the United States are citizens, but you also have folks that are undocumented and are legal permanent residents. And some of them are fearful of getting tested, either because they don't know whether that's going to affect their status or their ability to remain in the country. Or I have heard stories now of people who are simply afraid of the cost. They're afraid. It's almost like see no evil, hear no evil, where they don't want to avail themselves of the medical procedures because they're fearful of a multi-$1,000s in bills that's going to come to them. I'm also concerned that governors across the country are not aggressively testing at this point because they don't want to be the face of this pandemic. They don't want to be on the news every night the way that New York is. And so they're hoping that they can ride this thing out. And it's clear that the communities that are paying the highest price for that are often low-income communities and Black and Latino communities in the country.
Can I mention a couple of other things? Well, one, I'm concerned about the people who are incarcerated, and I also think of the detention centers. And we are calling for the early release of people, but I don't want to see people just released into the community unless they're tested and we're aware of that. So I think that we have to think about that as well as protective gear for folks who are the essential workers. And then the data, we need to have the data, because right now the death rate is basically anecdotal. The CDC is either, and the doctor might know about this, is either not taking or not compiling the data, or they're not disseminating it. But we definitely need to have it, to have the data. So we know what we're dealing with. And not just the death rate, the infection rate, hospitalization, et cetera, the whole picture.
You're absolutely right, Congresswoman. And I really didn't want to imply with the comorbidities that was some explanation for why African American and Hispanic communities were disproportionately impacted. It nevertheless, though, is a reality that the healthcare delivery system and our country's leadership needs to understand that disparity, how that's a deeply rooted disparity that precludes our ability to rapidly respond to a new threat such as a COVID-19. And that underlying lack of healthcare delivery interface with a population has got to be addressed for us. As we move back into changing our mitigation strategies, the case finding and contact tracing becomes the only tool we have to balance back transmission threats while we put people together more frequently and in larger number. So I strongly agree that the testing is critical. It will enable us to be rational about who we put back in group connection, who we allow to go back and be a doctor or a nurse in a hospital setting, or go back to work knowing that they indeed have had the infection and they've moved through it and developed antibodies. I also want to say that it's more complicated than that, because we don't know yet if these antibodies afford any protection for subsequent exposure. And so we are assuming that that is indeed how it will work. We're hopeful and likely, but I've practiced long enough to know that some viruses don't do that at all. You can make HIV is a wonderful example of a lot of antibodies that don't do anything, and you can get reinfected and reinfected with the same virus. So the science needs to move rapidly. We need to acknowledge, embrace, and accept the fact that the disparities we have in communities' reaction to this pandemic are largely dependent on the healthcare delivery system's ability to mount a response. If you're not interfaced with that community, you will not be able to change slopes of ascent and accelerate slopes of decline. That is managed best by community-based organizations that are already well interfaced with the populations of interest, in this case, Hispanics, African Americans, have credibility, are trusted, and we need, as the public health system, to take advantage of that interface already established and expand the capacity of community-based organizations that can take on screening, testing, referral, triage, et cetera, during this emergent need.
Well, let's talk about the two things. First of all, the need to go back and do contact tracing in the communities. And second, let's deal with the issue that Representative Bass raised about the incarcerated population. There are approximately 400 people at Rikers Island in New York alone who are there because they can't post bail. They haven't been convicted of anything. And we know from the people who've been released so far that 86% of them show up for their first bail hearing. And if you give them a second notice, 93% do. So depending on what they're being held, obviously if they're got bail, probably the offense is not super serious and they can't make bail. Don't we need a system which will enable, first of all, these prisons to have as much reasonable separation as possible, so you got to reduce the population, and to feel free letting people go, but as you pointed out, they have to be tested, and then they have to have some place to go. You don't want to send them to a place that's infested with the virus. So is there a special program that funds those efforts in any of these bills? And if not, should there be? And can we create a national movement which will make all these governors and administrators feel more comfortable with this? This is, even New York, which has adopted a real sweeping bail reform measure, still has 400 people in Rikers who can't post bail. So we've got to figure out how to do this nationwide. And we could, I've been amazed that more people haven't died in prisons already.
Well, we'll see, because I think the numbers are going to be quite explosive. Well, one of the things the Congressional Black Caucus pushed for, we didn't succeed this last time, but we're going to continue trying, is at the same time as we're calling for early release in a number of categories. For example, pregnant women shouldn't be in jail. You mentioned bail. There's also people that are in jail and prison because of technical violations. They didn't show up for a hearing or something. So how can you talk about social distancing and hygiene when that's not what can be possible in a prison? And so we were calling for resources to be put into reentry programs, so that the community-based organizations that work with the formerly incarcerated, we need to give them supplemental funding so that they can help make sure that as we are releasing people, number one, as you said, they have someplace to go, that they're safe. And it's an opportunity, and I mean, I hate to put it this way, but it is an opportunity to see what happens when we do leave people out for bail, like you just said. You know what, 90% of them come back after a reminder. So it's an opportunity to experiment, if you will, with some of the criminal justice reforms we were already looking at.
Joaquin, what do you think about that?
No, I agree. We've known for years that in terms of our bail system, there are people in jail who simply can't afford to pay. And this pandemic has shown the danger of continuing with a system like that. Karen mentioned earlier also ICE detention centers, for example, or the children's detention centers or shelters that HHS runs. Folks that are in these cramped quarters like that, just as the sailors who were on the USS Roosevelt and the Americans and others that were on the cruise ships, people that are in those close quarters like that, you have to be able to get them out of there and allow them to be in a socially distant place where the virus is not going to spread right away. And we've seen the spread quickly in other places, the outside of prisons. In South Dakota, for example, there's a meatpacking plant where hundreds of people have come down with the coronavirus. So, we have to be more attentive to places in our society that we tend to put people in a corner and then ignore them. We have to attend to those folks right now, especially.
Let me ask you this. Do we know, does Congress know, Eric, does the public health community know what our testing capacity is going to be in 1 week and 2 weeks? The reason I'm asking is, it seems to me, if I were a governor today, if I were in Governor Cuomo's position or Governor Newsom's position or the places where it seems to be growing in Michigan or Wisconsin or Illinois, I would want to know how quickly I could assure that if someone agreed to be a contact tracer, they could have safety equipment and they could be tested every day because they'd be going into places where they not only knew somebody had it, but they could assume that other people were also infected. And in order to do that, first of all, you have to have enough testing equipment so you can test the doctors, the nurses, the other public health workers, the people who are driving the ambulances, all of that. They deserve to stay alive, and they're risking their lives every day, the first responders and the healthcare providers. So how do we know we're going to have enough testing equipment to do it? And do we know when we'll have it? And then is there any system to prioritize contact tracing once you take care of those people?
So, Mr. President, I've been orchestrating with my colleagues at UCSF a case finding capability that we teed up because we knew it was going to be critical and necessary for any return to normal. And we also knew that our ability to do the case finding was directly dependent on our ability to do rapid testing, have results back not in 5 days a week or longer, but as rapidly as possible, preferably within hours. And that began a conversation, speaking just for San Francisco, that required that we talk to the public sector, but also in that much of the population is insured and in a third-party payment relationship. We, for the first time, had to begin a discussion with large third-party payers, Kaiser Permanente, et cetera, in San Francisco, and talk about a system that had a closed payment for testing, blood drawing, laboratory, human resources, et cetera, reserved for the people that had their insurance and their packages, matched against a expanding need that covered the entire population of the city. Who had jurisdictions? Were we going to synergize and share? Were we going to make everybody have their own separate lab? Or were we going to be economical about it? And I can't tell you how difficult that discussion was. We're talking to profit-driven systems for a healthcare emergency need where the public charge that you are responsible for the public well-being was not part of their self-perception. But it became part of their self-perception as the discussion proceeded. They realized, we all realized, that we had to take that step, and corporate thinking had to broaden into the public health need, and resources needed to move between. I think we are unique in that we were able to achieve that. It's a microcosm of what happened at the state and federal level, with a lack of a federal focusing on what we're doing, when we're doing it, how we're doing it, to draw a consensus around human needs and commodity needs that really still hasn't occurred to this day. So I kind of meandered around there, but I mean, I think that's it.
So what would you all like to say about that? And what can these young people who are listening, what could they help you lobby Congress to do to address these things?
Well, I think they could help us lobby Congress to do the testing. I mean, it's just inexcusable. And I think what has happened is that everything has been put out to the market. And so to add to it, something that confounds the whole situation is the promotion of hydroxychloroquine. And I know that they've just, distributed millions of tablets. And so I think refocusing us back on testing, back on public education, back on the contact tracing, staying focused. The other thing that's terrifying to me right now is you're seeing the beginning of a protest movement. I don't know if you saw what happened in Michigan, where you have people that were protesting the public health protocols. And I noticed as they gathered in those crowds, none of them had their faces covered, and they stopped traffic. So there were healthcare workers that couldn't get to the hospital. So I think pushing Congress to continue along the road that we are, to provide the resources and to make sure that we get the testing and the treatment and all of that is the best thing that they could help us do right now. And we need the outside help.
And to add what Karen mentioned, I think there's something that they can help with in the moment now, and then after this pandemic has passed us, this moment has passed us. In terms of the now, what I would add is that there has to be intense pressure on the Congress and our other institutions, both public and private, for honest transparency about what's going on.
Yes.
We've already seen dangerous examples of deception. For example, ICE was repeatedly asked how many of its workers and detainees had been infected with the coronavirus, and they repeatedly did not include the numbers from their third-party contractors who run ICE detention centers. So they lowball that number until they were caught. Another example is in my hometown of San Antonio. There were about 67 residents of a nursing home who became infected with the coronavirus. 17 of them ended up dying, but 5 of those deaths were not initially disclosed by the nursing home to the local government. In other words, they were going to cover up at least 5 of those deaths and not report them to the government. And so both our public and our private institutions need a lot of pressure right now to make sure that they're being completely honest and transparent. And then one more piece to that, when we move past this moment, as I mentioned earlier and others mentioned, that this has really exposed a lot of the inequities in American society. And I hope that we are closer to believing that healthcare is a human right, that housing is a human right, that everybody should be able to get a good quality education to pursue their American dreams, and that we can move forward as Americans towards that agenda.
And since the underlying health conditions have been exposed, we do need to get past this crisis. But then after that, let's focus on this, because these health disparities are not new. And now that there's some attention on it, though, we need a short-term and a long-term plan. And doctor, I don't know what you're finding, but one of the things I'm worried about, too, is that we don't know the long-term consequences of this, the lung damage, the kidney damage, So I don't assume that because somebody has recovered, that means that they're back to normal.
No, Congresswoman, I think you're right to raise that. I know your nurse practitioning background is coming forward there with an awareness of you see an acute event, but it sets a course for that individual that travels years with them. And I think you're prescient to say that we need to anticipate that what we know of the pathophysiology of this organism, and as we learn more over the next 3 or 4 months, we will understand the multiple organs that the viremia, during that initial viremic phase, it lands and does damage. Some of it's permanent. And we need to understand that over time. I think also it was tragic to get people focused on, as this epidemic broke, to be thrown down a line of therapy with the hydroxychloroquine issues, the remdesivir question, the question initially of Kaletra, an antiretroviral for HIV. It's always the way these outbreaks happen. People think of therapeutic interventions. Those therapies really would be used first for those who are in extreme. That would be people who are in ICU level care, most of whom would be intubated. And to see if in the most ill, you're able to change the course of that individual. And then it comes back out into less ill uses. But it was a divergence, I think, that in part pulled us off of the focus that was needed for the testing to be implemented aggressively and rapidly. It put people's attention and resources even followed it because people are that scared, and it's completely understandable, but it was a divergence.
Mm-hmm.
I agree with that. I just want to emphasize to everybody who's listening to you how profoundly important it is that you get the support you need to get enough testing. Most people still have no idea how many millions and millions of people we need to test at no cost to themselves if you want to get this economy going again. And secondly, how much PPE, protective equipment, we need for the people we want to do those tests. And if you want to do contact tracing, you've got to protect the people you want to do it. Mm-hmm. And I still believe that we haven't paid enough attention to this. I also, one of my personal obsessions is that the states and the cities and even individual hospitals have been left to play the eBay game in terms of bidding for public supplies, which I think is a disgrace. We're winding up paying too much for a lot of this and getting too few people supplied quickly enough, and it's costing people lives. And we should have done it differently. The way Eric and I worked so hard to do AIDS drugs for so long, and the way we try to do TB medicine and malarial medicine, lots of other things. We shouldn't be doing this. But I don't think you've got any way to force a different system now. But at least you should be supported in making sure that these healthcare workers you want out there are protected and doing their job. Because every day, people have no idea, the average person, the sheer volume we need of masks and protective gear for the people that are already out there just treating people in hospitals or bringing them to hospitals. But there are all these other people we need to be able to sit out there in the world. That's why I'm thankful that the governors are telling people working in grocery stores or going in there, they should wear a mask and other things now. Mm-hmm. But we're just at the beginning of this. If we're really going to contact tracing, we are going to need so much more protective gear than people know. And the members of Congress need the support of people who will tell the Congress and tell their government not to fool around with this and not to allow the worsening of these economic and racial disparities when we ought to be using this to set a path that will get rid of them. And I'm very grateful to all of you for doing this. I don't know if there's any other point you want to make, but we've got 6 minutes left. So if you want to say something else, please say whatever you want.
Well, I would like to. I had mentioned earlier that my concern about this emerging, well, what I hope is not an emerging, but this protest movement of people saying we need to open up our economy and we need to go out. People who are listening to this need to counter that as well. It needs to be driven by science and not by politics. And if we push and people are going to openly object to the public health guidelines, there needs to be a very loud voice countering that. Otherwise, I don't know how the curve is going to be flattened. We're just going to have a whole nother spike if this is the direction that a lot of people are going to take.
Well,
And I would add to that, oh, go ahead, Mr. President. Sorry.
I just was going to say, color me skeptical. I don't think they happened by accident, and I don't think they
Right,
happened.
absolutely.
Somebody put them up to it, and they ought to stop it, and it needs to be uncovered and called out.
I think it's
Go
a
ahead,
TV
Mark.
network, but okay.
Yeah.
As Karen mentioned, this protest movement that's growing, and a lot of that anxiety, I believe that a lot of it is being ginned up by one particular group of folks, but a lot of it also is based on the fact that people are now out of work and they're wondering how they're going to pay their bills. And so I know our session has been mostly about the health part, but making sure that we're healthy, to make sure that we're healthy, we also have to make sure that the government is delivering relief economically to people so they feel that they're in a better position where they don't have to go take chances out in the world when there's a pandemic going on. And I can speak to my home state of Texas, where the delivery method for getting unemployment benefits to folks, for example, has been quite poor, unfortunately. A woman told me the other day that she called the Texas Workforce Commission 103 times before she was able to finally get through. So I think some of that anxiety is people feeling as though they're going to drown in debt or face the prospect of eviction or otherwise need to go out into the world to make money. And so the government has to do a better job than what it's done so far in offering people economic relief as well.
Well, I agree with that. I think, first of all, if you look at the early surveys, when Americans were asked, what are you going to do with the check you get? Almost all of them said, I'm going to buy food, which means they need mortgage or rent. We can't have people being thrown out of their homes because of this. Since we know that sooner or later there'd be a massive public uprising, we should take care of it before they're thrown out.
That's right.
Because the money they've gotten is too little to do anything but feed themselves. And I think that's really important. And I appreciate you saying that. I also believe that look at the price we paid for ignoring the early warning system. We paid a terrible price for the delay in dealing with all this, and that makes it more costly to do now. But you're right, the working people are obviously worried about having enough money. Most people, before this happened, half the people in the country said they would have a very difficult time dealing with something that cost more than $400 that was unanticipated. So we got to protect their basic human needs, and that's got to be, if there's going to be another bill, we have to face the rent and mortgage implications of what they're facing. But they need to understand that we can go back to work more quickly if we do it under conditions when you're not going to have to turn around and just impose another shutdown 10 days afterward because thousands of more people die. They don't want that either. So I'm glad you said that. We should all be sensitive to what people who don't have any cushion feel. But we won't help them if we put them in the harm's way where they can lose their lives or they cost someone else theirs. We don't want to do that. Eric, you want to say anything before we go?
Well, thank you, Mr. President, and thank you both of you for your I think really insightful comments. I believe that we are at a crisis for the African American and Hispanic communities that is wrapped in this pandemic. It is up to individuals like yourselves who can connect the dots. But I hope this puts a surge of commitment, interest, and urgency in the country to deal with these issues of disparity around healthcare, understand the connection to the economy and our country's ability to rise up as a nation. We cannot have inequities in access and performance that we continue to allow. And I believe the government needs to be much more aggressive in defining, understanding, quantitating, and addressing these disparities across the board, from health to education to housing, homeless, prison populations. We can talk about disparities in all of those arenas. So thanks for this opportunity, and I look forward to trying to think of ways to this for this to take on momentum and get legs.
I want to ask you to watch closely what they try to do in Congress and try to give your support to it. There are things we can do that will reduce the death rate by race and by income. But the truth is, we need universal access to health care. The Medicaid expansion will get us to 97% or so if we can get every state to adopt it. And we need actual care for people who are out there being our first responders and healthcare workers. And they're disproportionately in New York, for example, members of the Latino and African American communities, along with a lot of Asians and others who are first generation immigrants keeping us safe. This is something we have to deal with together. And we have to recognize that this is horrible in its own right, but it also has laid bare the fact that we don't have a public health network in every community in America that is adequate to this. And we, again, I will say, we have got to replenish the stockpile until we get massive amounts of protective equipment and the other things like the ventilators we need in the event this happens again. But we have a lot of work to do right now. And right now we don't have the tests or protective equipment to do it. If we can do it, we can begin to go back to work and we can begin to get rid of the disparity in deaths. Thank you.
I'm Katrina Villas-Cisneros, and the future is fighting for human rights.
The future is fighting the opioid epidemic.
The future is fighting climate change.
And protecting natural resources.
Tackling domestic violence.
Empowering refugee women.
Zero discrimination and equal job opportunities for everyone.
Equitable access to education.
Tackling substance abuse.
The disaster resilient world.
The future is empowering the next generation of leaders.